Hello, everybody, and welcome back to Contagion's live podcast, From Pathogen to Infectious Disease Diagnosis. I am Rodney Rohde, your host today. I am with the Texas State University College of Health Professions and chair of the Medical Laboratory Science Program. Today, we welcome back Dr. Jose Alexander to our show, where he's going to discuss a recent topic on pneumococcal disease and genotyping, as well as some other areas in that. Welcome back to the show, Dr. Alexander.
Thank you, Ronnie. A pleasure to be here again.
So today we are going to jump right into to your article, which I found fascinating. It's really a nice review and update on how genotyping and whole genome sequencing and other characteristics around pneumococcal disease are so critical. I know your article really jumps in and highlights the devastating global impact of pneumococcal disease, especially in our younger children. Could you elaborate a bit on the specific challenges in fighting and combating this disease, especially in developing countries that have, as you know, limited vaccine coverage?
Yeah, I think this is an important topic, especially because we know that vaccination can be a little bit difficult, especially in developing countries. We have organizations like the World Health Organization and other entities that have been working to bring vaccination to developing countries, but we can find some gaps. We can find vaccines that are available in those countries that don't cover for some of the serotyping that are circulating. We can find also gaps across the regions of some areas when some population can be vaccinated and others are not. And this is interesting because there is two significant serotypes that are being seen in Africa, like serotype 1 and 5, that even when there is vaccine already covering for this particular serotype, the interesting thing is it still persists circulating in the population. So that gives you an example of how gaps in the vaccination and the population, especially children, allow for this specific serotypes that are covered by the vaccine, still circulating in that community. There is another aspect of this. So some of these countries, low income countries, have no access to a specialized microbiology laboratory. Isolation, identification, and even susceptibility testing for Streptococcus pneumoniae can be really challenging. So if they don't have the resources, we can see how these diseases can be underrepresented or even underregistered. The other aspect is the access to serotyping or genotyping. In some of these countries, that could be centralized through a public health department that is based on a centralized laboratory. So being able to screen for a significant amount of these organisms to be able to detect the circulating serotypes can be challenging. So we can find gaps in the surveillance data, and this surveillance data is critical for us to be able to inform the next generation of vaccines.
Yeah, I know it's interesting in your paper when you discuss, you kind of review serotyping, and I'm sure our audience probably knows what that is, but I even, in my past, and 30 years ago when I was working at the Department of Health in Austin, we did a lot of serotyping, including with viral types of serotyping. So could you talk a little bit about those serotypes, the difficulty, and even sometimes the subjective nature of serotyping with respect to pneumococcal disease and how it's really so important to inform really our development and effectiveness of those vaccines?
Yeah, well, some of the interesting thing is there is a specific serotypes that are being responsible for a large amount of infection, probably close to 10 to 13 of this serotyping has been the responsible of maybe more than 80, 90% of the cases of invasive pneumococcal infection. So the dynamic is, and it's very interesting, the dynamic, and it's very simple. We have serotypes that are currently circulating that we identify them through epidemiology and surveillance data. Vaccines are created and we target these prevalent serotypes. But then we have the serotype escape, right? The serotype escape is those where vaccine, they are not included in the vaccine that are currently being provided. So these serotype escape become now the most prevalent serotype. Then the next generation of vaccine or the data that we accumulate during years inform for this next generation of vaccines to include this new serotype. And this is a game. So it's kind of like a cat and mouse game. We have serotype like the 19F that was the PCV vaccine 7. And then when that was covered, then we found the 19A that become one of the most prevalent. And there is an interesting thing there, because here's when they came to play serotype and also the clones that we normally identify as the sequence type, the ST. So there is a correlation between them, but it's important to know beyond the serotype, because we know that the clone itself has a history. We can track the history of the organism based on the strain. So, for example, mentioning about the case of the 19F, there was a serotype prevalent before the PCV7 vaccine. This particular serotype was associated with a clone called SP320. That clone was known to be penicillin resistant when the vaccine, the PCV7, arrived. So the prevalence switched to the 19A serotype. The interesting thing is this new 19A serotype was still associated with ST320. So we were dealing with exactly the same organism. The only thing is the organism read itself with a different coding, in this case, and different serotypes. So the dynamic is being present. And when the PCV13 was included, now we have serotypes like the 22F and the 33F, they become now the prevalent. So this is a race, right, against this organism. And this is why it's so important that we nationally, globally, but also regionally, and we're trying to do is, can we inform our own clinicians and all healthcare officers about the circulating strains and serotypes in our region?
Yeah, I mean, when I think about, again, all of these topics around, in the United States, for example, you typically have the advantages of our hospital laboratories, at least in big systems, where you at least are having that identification and that susceptibility test run, right? But as you know, a susceptibility test or an identification at the level that we typically have, even here in the US with our technology, can be limited. I mean, one shoe does not fit everybody. And I love your cat and mouse comment. I actually wrote that down because you can't just understand just the child's infection as pneumococcal. You really, really critically need to know the strain or the genotype, because without that, you could literally miss, a treatment regimen that might affect the actual child's health. So I really appreciate that. Antibiotic resistance, we know, is an ongoing concern in society globally as well as in the United States, and especially with the kind of the predominant serotypes that you were talking about. Can you speak a little bit about how genotyping these specific invasive pneumococcal strains contribute to kind of tackling and tracking that type of resistance? What are the implications for treatment strategies when you start kind of intersecting with resistance?
Yeah, I think this is an important aspect, and that's where the genotyping of the organism or identifying the clones or the sequence type is a critical role. If we look the clone of the HT number as a history for the organism, we can see where the organism has been. We know what type of virulence factor is this organism being related with. So being able to access to this genotyping, being able to identify the clone is another layer of information for a clinician. If you have a patient, for example, is in our hospital and the patient the children with an invasive pneumococcal infection, and we are able to provide the identification and susceptibility test. But if we can provide the genotypes and say, this is a clone 156, for example, that is being related with ABAIM and meningitis, and these children actually have a sepsis, we need to keep a close monitoring, because we know that this clone, based on publication and based on cumulative historical data, has been related with meningitis. So it's important to also consider what are the implications of this strain. We treat based on clinical guidelines. We also treat based on the susceptibility testing. But knowing the type of clone that is present can actually give us an idea what could be the possible outcome. Is this patient probably requires double coverage? Is this patient will require a more close monitoring? But the other aspect of that is, well, if we know that a specific clone is related with a specific serotype. And we found a clone with a different serotype. And we actually see a serotype switching. That is something common in Strep pneumo. So it is an important information that can be passed later, because now we can have the same old aggressive organism. They just simply switch the capsule and is able to escape the vaccine. So this is the type of information that is important for epidemiology. But from the perspective of the treatment, it's critical. I know that we traditionally use organism identification and susceptibility testing, but being able to evaluate and know what type of flow we were dealing with, they can provide to pediatrician and even to adult, being able to monitor this patient closely and be able to evaluate the potential outcome. The other important aspect of this is if this serotype escape or is a vaccine breakthrough. So if this patient receive a vaccine, the cover for this infection serotype, what exactly happened? The patient didn't seroconvert. If there is any immune deficiency that we are not able to see, or when the patient get antibody against specific serotype, are we able to see if that antibody is high enough to be able to provide protection to this patient? So this can actually also drive the management post-infection.
Right,
what type
right.
of booster, what type of antibiotic this patient should be, or type of vaccine this patient should be receiving.
Yeah, I mean, it's really exciting, right? When you think about, most of the time as a clinical microbiologist, or even a public health microbiologist, we're thinking about, how can we maybe track, like through surveillance and epidemiology of cases. But what's interesting, as you mentioned, these tools will do that, but now we can also monitor therapy in a sense, in a way that we might switch therapy, we might help in the development of vaccines as that escape happens or that resistance profile happens. Yeah, it kind of makes me think back to basic microbiology, right? Just to bring it into the conversation for our audience. Remember, when you're thinking about Streptococcus pneumoniae, those capsule types, that outer covering virulence factor is what we're talking about here. So this bacterium is notoriously changing that capsular makeup, and then your immune system has a really difficult time keeping up that. In many ways, kind of a similarity to SARS-CoV-2 switching its spike proteins, just kind of a different agent. Your article talks.
Just to mention something that's actually important that you indicate. So when we see an invasive pneumococcal infection, we are dealing with a serotype escape of a vaccine breakthrough, right? Because if the patient is vaccinated, we know that it's a breakthrough. The patient is vaccinated or is not vaccinated with this specific serotype, that is escape. So these are the two entities that we normally will be able to see. The other important thing is how they inform is this scenario. Children, they have an invasive pneumococcal infection, and the organism compounds susceptible. But then we found that by the clone, the strain is a 306. 306 is related with serotype 1. It's a pan-susceptible isolate, but it's known to be a hypervirulent strain. That means it's easy to spread, have some mechanism that allow them to be more pathogenic. So even when the organism can look susceptible based on an ASCP data, the serotype can inform that we're actually dealing with a highly virulent strains that don't necessarily have to be multi-drug resistant. So this is the other part of the equation that we try to provide the clinician with information for management and treatment.
Yeah, your article title kind of hits that. You say that genotyping is a game changer, right? And so I think in many ways that technology that you talk about improving the management compared to traditional methods is pretty critical, right? Going forward.
Yeah, exactly. Yeah. So that's one of the major roles. And giving this information to pediatrician and adult physician is critical, because actually can add another layer of how we are evaluating and assessing this particular infection.
Yeah, and it's great to have you on to talk about this, because the entire podcast that we've kind of started is really this laboratory medicine clinician conversation, including ID pharmacy, right? There's this whole kind of world that we need to continue to break down silos and continue to share this information. When you think about whole genome sequencing specifically, how do you think that's revolutionized infectious disease diagnostics?
So whole genome sequencing at this point is an accessible tool. I still can be considered as a scary work for the laboratory, especially for the clinical laboratory.
Right.
It's difficult, it's expensive, it's challenging. Well, it still has to be, you have to create your own next generation sequencing uh, solution. It's kind of off shelf. You go off the shelf, get all the parts and put it together like a recipe. But right now, there is access to reagents, instrumentation, and testing that can allow clinical laboratories to implement these tests from the perspective of a microbiology. And this is a two different approach that we have implemented in Advent Health. We have the approach for diagnostic that provides testing directly from patient samples. But there is also an application for the microbiology laboratory to be able to cover for gaps that we are assuming they are there, and we just feel comfortable that they're there. For example, why we're not able to identify all mycobacteria in how we do with bacteria? We're still relying on reference fungi. You need to have a high expertise to identify them visually, but I mean, really beyond the Aspergillus group and many other possible fungi, it's challenging to identify the species level. So we feel comfortable with that and we accept that. So the same point is, well, whole genome sequencing from the laboratory perspective can allow us to identify this organism to a genome level, can allow us to be able to expand Streptococcus pneumoniae evaluation and go to typing and even for serotyping. So whole genome sequencing is a significant tool for molecular epidemiology. And this is something that we have been implementing at Health for the last 2 years, because we want to be able to provide solutions from the micro lab beside the direct sample diagnostic that is significant, but still there is gaps that we need to be able to cover. The best example for a molecular epidemiology outside Streptococcus pneumoniae. So we have cases that it's brought to us in our own Advent Health system that before we have the suspicion they could probably have a cluster. We have some organisms from patient in a unit that require epidemiological investigations, start reviews, case review, interventions. So now we actually revert the case. When in Advent Health we have this suspicion that we could have a cluster, they come to us first and we are able to do a whole genome sequencing of the organism. Are these organisms related or not? If they are not related, there is no reason to do a full epidemiological investigation. It was just a coincidence. But if they actually related, now we have the tool and the information that can trigger an appropriate epidemiological investigation, knowing that these organisms are truly related and they probably can come from a specific source. So this is probably the beauty of whole genome sequencing, that gives us the inside of the organism, and you don't need to have access to significant amount of resources, because right now there is a lot of databases available that allow to do this type of analysis.
Right, right. That I think what's one of the important statements you just made there, and people probably don't think about, is that not only can you positively affirm sequence types or different management sequences, but you can also say, hey, this actually is not what we thought it was. We're gonna save resources. We're not going to send out a ton of types of a team effort to kind of think of an outbreak. It's actually not an outbreak. They're not related. That's an important statement, because in our current environment of being fiscally responsible and all that stuff around public health and clinical health, I think that's going to be a really important factor going forward. So in many ways, I think genotyping, as it goes forward, it really is going to influence, clinical outcomes, treatments, and vaccines in a way that can be hopefully fiscally responsible and
Exactly.
able to really be more exact, which is what we want in medicine.
I
love your use of the term molecular epidemiologist. That was my title 30 years ago. It was kind of a new title at the Department of Health, and I don't think people knew what I was doing. I was typing rabies virus strains for different variants of rabies, because you can have canine and skunk and bat and so forth. It was so new, and I guess it's all kind of coming full circle, because when I talk to individuals like you or other people that we've interviewed, to see this coming to fruition in healthcare, And I want to make that emphasis. It's not just in public health labs. It's not just sitting at CDC or the departments of health. It's literally happening in hospitals. So again, I really want to thank you for this conversation. I'm gonna kind of wrap up here and let you make any final comments about this. But you say in one of your paragraphs, why should a frontline clinician care about the serotype or sequence type of the pneumococcus causing a child's sepsis, for example? And you answer, because not all pneumococcal cases are created equal. Some types are more dangerous than others, and knowing the type can inform prognosis, therapy, and prevention efforts. What are your thoughts on wrapping that up on that conversation?
That's what we're trying to provide for a clinician. And I will say that, I mean, when we start discussing about the implementing whole genome sequencing beyond identification and even molecular epidemiology, the topic of strep pneumo genotyping came in the conversation with a pediatric team and ABAIM Health and my microbiology team that, by the way, is the best group of clinical laboratory scientists that I have been able to work with. They are completely dedicated to this new approach with whole genome sequencing. So when we bring this to the case, we ask the question to the pediatrician is, what can you do if we give you identification today, susceptibility tomorrow, and the next day we tell you what type of serotype and a strain you're dealing with? And the question was, well, I can actually use this information along with my susceptibility to maybe adjust, improve, escalate, or optimize my treatment if I know that the strain is known to be a multiviral. I also be able to maybe have a different approach if I know that the strain is a hypervirulent strain.
Right.
I can evaluate if my patient was appropriately covered by the vaccine. But the other important thing is parent. If the kid have all the vaccines, and suddenly get infected with a streptococcus, with a pneumococcal, with an invasive and severe infection, what happens, right? What happened to my kid if I follow the vaccination process? So this is an answer, and this is a tool the pediatrician can use to have this discussion with parents. Well, the vaccine actually didn't cover for this serotype. Or the vaccine was appropriate, but the children didn't develop the appropriate immune response. So this can inform parents of what is the next step for the children to be able to protect it in any future infection. So, and we want to be able to track this. So we're offering this service in ABAIM Health for 48 hours turnaround time. So we don't want the patient to get this report 2 or 3 months later. We want to be able to provide this result when the patient's still in the hospital. And this is a service that we also opening for hospitals across the nation. Not only for children, but we also thinking that adults can be an important group of patients to screen, especially because we know that streptococcus infection, it is a pneumococcal infection, is not only in children. We know that patients over 50, 60 years old are also susceptible to this infection. So I think it's important for us to track what type of serotype can be circulating in that group of patients.
Yeah, fantastic. It makes me think, as you were talking, and it's something I often talk about, it's really exciting at this time in our abilities and our technologies and the platforms we're starting to look at, because I think we really are. We're not quite ahead of the microbe, but we are closer than ever before, right? I think real-time medicine, real-time precision medicine is on the cusp of what you are doing and what others are doing. So I thank you for your time. This is such an incredibly important topic. And thank you for joining us here on Contagions Live podcast. And I look forward to your work and your future publications. Hopefully we'll have you back soon.